Hello, everybody in podcast land. I'm Dr. Ted Thatchencary, and this is MD Roundtable, a podcast about collaborating and learning from other healthcare professionals from all over the globe. We are all so much more connected due to technology. We have so much to learn from each other. Thanks for joining us today at MD Roundtable. This is a very special episode as we are featuring Dr. Jasleen Pannu, who is Medical Director at the James Lung Cancer Early Detection Program. She is also Director of Interventional Pulmonology, Translational Research at The Ohio State University Medical Center. Welcome to MD Roundtable, Dr. Pannu.
Thank you so much, Ted, for having me. And thank you for that great introduction. So I'm very excited to talk to you.
Likewise, Jasleen, I'm very excited to have you on. First off, let's start off with your journey, Jasleen, if you don't mind, for the listeners. Where did you grow up?
Absolutely. So I grew up in a small, close-knit city in northern India. It's called Chandigarh. And it's a city where community, education, and service are deeply valued. So my childhood was filled with books, curiosity, very strong family ties, and it laid the foundation for everything I do today.
Fantastic, Jasleen. Who was your biggest childhood influence on becoming a physician?
Actually, I do not have any physician in my family. I was literally the first physician in my family. So my childhood influences were the physicians who I saw in my treating us. So our family physician, whenever I would go to a doctor's office, I would be enamored by the tools and the sights, the white coat. Even the smell was really intriguing, even though that may be gross to some other people. So I was really intrigued by those sites. And I think the second influence was the amount of support I received from my home, my parents, where they said, if you have the ability to help someone, don't wait. And if you can be in that position, that would be the most incredible thing to do. So that really stuck with me. And then slowly over time, this steered me towards medicine.
That's wonderful, Jasleen. Yeah, way to break that ceiling, especially in your family for being the first physician. So kudos to you. Where did you end up going to medical school and where did you do your specialty training?
So my medical school was in India, in Goa, and then I moved to US for my internal medicine residency in a small town called Youngstown, Ohio. I further pursued a few different fellowships. I did my critical care fellowship at the Mayo Clinic in Rochester. Then I did my pulmonary fellowship at Bridgeport Hospital, which is one of the Yale hospitals in Connecticut. And then finally, for my interventional pulmonology fellowship, I moved to Nashville, Tennessee at Vanderbilt University. So I traveled different states of the United States, explored it through my education journey.
This episode is sponsored by Butterfly Network, creators of the Butterfly IQ3, a next gen handheld ultrasound designed for how clinicians actually work. In lung ultrasound, you typically need two probes, a linear for pleural sliding and a curvilinear for pleural pathology. But the IQ3 combines both in a single device. Thanks to Butterfly's ultrasound on chip technology, you can assess both lung findings using one probe without even switching between presets. And the curvilinear setting is best in class at detecting A lines and B lines. Butterfly's digital technology means faster workflows, fewer interruptions, and true portability, ideal for critical care, emergency medicine, and bedside protocols like Blue or Rush. Add in AI powered features like the auto beelines, counter for instant beeline measurement, and the IQ3 becomes a powerful tool for managing pulmonary patients with speed and confidence and helping gauge disease severity. Explore how the Butterfly IQ3 is streamlining lung imaging at butterflynetwork.com. Use promo code MDRoundtable25 on the Butterfly e-commerce store to receive a complimentary soft case mini with your purchase of a Butterfly IQ3. That's wonderful. Yeah, that's quite a journey. What made you interested in interventional pulmonology, Jasleen?
So I was always intrigued by procedures, but I did like forming long term patient relationships also. I liked being able to make a difference where I would be visibly able to see the outcome of what I did. And interventional pulmonology gave me both. It was where the art of diagnosis was meeting the precision of technology, also the art of therapeutics was backed up by technology, and being in that minimally invasive space where you could make a difference for the patient without having to do aggressive surgery and having the patient go home the same day was incredibly intriguing to me. So whether it was diagnosing lung cancer with robotic bronchoscopy or relieving somebody's shortness of breath with the airway stenting, it was deeply gratifying to me. So that's why I'm here in interventional pulmonology.
That's amazing, Jesseline. Thank you for sharing that. Well, switching gears, I think it would be beneficial to discuss the latest in lung cancer screening for our listeners. As you know, this is a very, very important topic. Overall, lung cancer is the leading cause of death in the United States from cancer. So, can you describe just some numbers, Justine? Like, what are how many new lung cancer cases get diagnosed yearly in this country, and what are the main risk factors?
Absolutely. So in the US, over 230,000 new cases of lung cancer are diagnosed each year. And like you said, it is the leading cause of cancer related deaths globally. In fact, it causes more deaths than breast cancer, colon cancer, and prostate cancer combined. So the impact lung cancer is having is just immense. But that also means that there's a lot of ground to make difference. In terms of risk factors, smoking does remain the biggest risk factor that we know of, which has been proved through several studies. But we are increasingly recognizing risk factors in non-smokers. In fact, in some Eastern countries, Asian countries, you're even noticing the rate of lung cancer is actually increasing in non-smokers. And the risk factors that we know of for now, radon exposure, which is something that can be checked into in our homes and can be remedied. Air pollution is a big risk factor, and family history or that may go back into genetics is also something that is coming up as a prominent risk factor, especially in patients who don't smoke.
Yep, that's very very interesting. I know in like sub-Saharan Africa and certain countries where they use like charcoal for cooking and certain biofuels, that's a risk factor, correct?
Absolutely. And these risk factors are very regional. I was recently visiting Middle East and UAE, and they brought up incense exposure is very intense there. And in closed homes where incense is almost used in everybody's home, but in a very closed environment, and it has a very strong smell to it. And it was actually very strongly associated with nasopharyngeal cancers or cancers of the oral
Hmm.
airway, as well as possibly lung cancer. Why we don't know that much in detail about every single risk factor is the lack of literature and studies to study every single of such risk factors, how regional they are. So, but overall, there is concern through one study or another, or case reports or case series of all of these contributing towards lung cancer.
Hmm.
That's why we like to say that to keep your lungs away from cancer, breathing clean air is the best thing one can do without any smokes or toxins or fumes.
Yes, yes, I agree. Now, you mentioned smoking as the biggest risk factor. Now, what about the cases you see in non-smokers? How many cases are diagnosed yearly for non-smokers?
I would say at least 20% of our population that is diagnosed with lung cancer does not have a history of smoking or has a very minimal distant history of smoking. So that's why we say that anybody with lungs can get lung cancer. And that is why there is a lot of upcoming research that is happening
Hmm.
around risk factors in non smokers, including further study into family history and genetics, as well as environmental exposures, especially air pollution. So about that 20% of population is that population that does not smoke.
Yeah, I think that's a very important statistics for the listeners to understand that as well. Today's podcast is sponsored by Cure.ai, a global leader in computer vision and generative AI solutions for CT and X ray imaging, currently deployed in around 100 countries. Recently FDA cleared in the US, Cure.ai offers a comprehensive lung suite, including advanced computer vision AI for CT, AI enhanced X ray analysis, and integrated patient management powered by generative AI technology. With radiomic capabilities and risk stratification tools, Cure.ai has demonstrated proven benefits such as reduced CT reading times, enhanced detection of small nodules frequently missed on traditional X rays, and a significant reductions in false positives. It streamlines patient management by minimizing manual data entry typically required by navigators. Visit cure.ai, that's QURE.ai today, and discover how cure.ai is transforming lung nodule detection and management. So, what have been some of the new screening guideline changes by the American Cancer Society, and how has that impacted the numbers?
That's a great question. So, recently in 2023, the American Cancer Society expanded the eligibility for lung cancer screening. So, traditionally, 55 to 80 years of age was the age limit for lung cancer screening, and people who have smoked 30 pack years or more were eligible. Now, the age limit has been expanded to people between 50 to 80 years of age and who have a 20 pack year history of smoking, and who currently smoke or have quit within the past 15 years. And these are also mainly expanding because, like we were just discussing, these age limits as well as number of pack year limits are not very strict limitations on who will get cancer or not. And now we're finding out cancer more and more in people who may not have met this eligibility criteria. And I anticipate that in the future, these may expand further, or we may get additional tests that may be either a pre screening test for lung cancer that can help us sort of screen that population that is at the highest risk in almost a different way. So we are directing our screening towards the ones that most need it.
Yeah, yeah, no, that's a really important fact. I remember when I was in training, it was just a good old fashioned sputum cytology and a chest X-ray back then. So I'm glad things have changed and we've come a long way. So can you describe, Justine, what is the lung cancer screening test and how often does one need it?
Absolutely. And, actually, I was at a conference and we were talking to patients, and one patient exactly asked me this, that you just had a comment on this, that why has my doctor not yet prescribed me lung cancer screening, or why wasn't I screened? I got diagnosed with lung cancer in 2018. And the reason is exactly this, because when we were learning, lung cancer screening or CT screening was not a recommended modality. So it is this new kid on the block, and it is just trying to make its place, and it has incredible impact. And it is a very simple test. So we use a low dose CT scan for lung cancer screening. It's a quick 5-minute test, does not require any contrast needles, and just requires the person to go into the office, or the screening room, or the CT screening room. Does not need to be empty stomach or anything like that. And the CT scan is done probably under a minute, and then the person can go home. And usually through these screening programs, there is a staff that is dedicated to call the patient with results. And if there are any concerning findings, there is a system on how they can refer the patient to follow up clinics or other referrals that can help them.
Okay, and you mentioned the low dose CT scan, Justine. Can you just tell the audience what's the difference between the low dose and a standard CT scan?
So, a low dose CT scan essentially uses less radiation than a standard. CT scan. So because of that, the radiation exposures is much less as compared to what would be in a standard CT scan, and somewhat similar to what there would be exposure to in an X-ray, like a spinal X-ray. So in this way, we are trying to limit a cumulative exposure of radiation through a patient's life. So there's not much risk factor associated with it.
Got it. Got it. Thank you for clarifying that. And how often is this test required?
So if the first scan is normal, we recommend repeating it annually. Now, if there are any concerning findings found in one of the CT scans, then there may be a more frequent CT required, or there may be additional testing required. But as long as they are not concerning findings, they can be repeated annually until the patient is eligible.
Got it. Okay. And who should not get screened for lung cancer?
So, anyone who has a serious health condition who would not be able to tolerate treatment for lung cancer in the first place is bedridden or just won't be eligible in that realm, or is above the age limit, it may mean that this test may not benefit them. So those people can forego screening if they have to. Also, technically, for people who qualify for screening are the ones who have smoked within the last 15 years, 50 to 80 years, and have a low cumulative tobacco exposure. So currently, these people are not recommended to be screened. However, I say that with a pause because this may change in the near future, considering how much we are trying to study genetics. And the underlying part, which is really important, is something we call shared decision making. Anybody who chooses to get screened or has any findings on screening or chooses not to get screened should do that with full information and following a very detailed dialogue with their primary care physician or a pulmonologist or healthcare provider. And there should be a decision taken with mutual exchange of information that is agreeable to both parties. So you can choose to be screened or choose to be not screened, but I would urge to be fully informed about the pros and cons of screening before taking that decision.
Very well said, Jasleen. So, can you explain how lung cancer screening has impacted patient outcomes, like survivability?
Absolutely. So, one thing is how much it has impacted now, and the other thing is what is the potential for it to impact these outcomes in future. So, it is proven through several studies over the last decade that screening with low dose CT scans reduces lung cancer mortality by 20 to 25%. It catches lung cancer at an earlier, more curable stages. So that is the most incredible impact. But I just want to elaborate what that could mean for lung cancer because its real life impact could be so much more. So when I say that it helps to diagnose lung cancer early means that in these studies it was found that the cancers are found at an early stage, stage 1 or 2. About 60 to 70% of them are presenting early, whereas in real life 70% of lung cancers are found in stage 3 and 4, and the survival from lung cancer is close to 25% at this time, which is pretty low as a 5-year survival.
Mhm.
If they're found in stage 1 or 2, the survival can be over 70%, over 90% 5-year survival if it was stage 1A. So just imagine the impact
Mhm.
if we were to flip this number and actually find most of the lung cancers in an early stage rather than the later one. If three-fourths of them were found early, there would be so much impact in this survival rate that is as low as 25% as of now. And we often encounter this question that mammograms are very common, colonoscopies are very common. Where does lung cancer sit in this? And there may be a myth that you have to do a lot of CT scans to find one lung cancer, but in reality, I just want to quote some numbers. For finding or saving one life from lung cancer, you need to do 320 CT scans. To save one life from colorectal cancer, one has to do more than 850 such tests. To save one life from breast cancer, one may need to do over 1,000 such tests. So the number that you need to screen to save one life is actually much lower for CT scans. So
Hmm.
it is actually more effective than the screening tests we currently have. It's just something that the patients, the population, as well as healthcare providers may not be aware of. So there is an incredible need to spread this information so that there can be more confidence and more
Hmm.
enthusiasm towards this testing.
Yeah, no, those are very intriguing numbers, Jasleen. So, from what I'm understanding, what you're saying is it's not only about early screening, it's also early diagnosis and early treatment.
Absolutely.
And kind of, to further explore that, can you share how you would diagnose these nodules early, and maybe some of the modalities that you use for diagnosis?
Yes. So as the number of CT scans we are doing are growing, we are finding more of these spots in the lung or nodules in the lung that could be early lung cancer. And when we find these spots, we don't want to just wait on them for them to grow to a certain size. So over the last decade, several technologies have come in where we are able to now diagnose and treat smaller and smaller of these nodules. I remember when I was training or when I was in my residency, say about 2 centimeters or more were the kind of nodules one could go further with or surgically resect. Now, we very routinely go towards sizes, sometimes a centimeter or even lesser, with our diagnostic tools. So, equipment like robotic bronchoscopy, which allows our catheters to almost reach pleura. So, we can almost biopsy pleural nodules, multiple of these nodules within the same procedure. We have endobronchial ultrasound, where in the same procedure, you can diagnose what the nodule is and also stage the patient in the same procedure to see if any of the lymph nodes are affected. And the most latest thing for us to even treat lung cancer as early as possible is that there can be these single anesthesia procedures if they are large enough teams that can coordinate that, where in the same procedure, you may be able to undergo a biopsy, a staging with the help of a bronchoscopist or an interventional pulmonologist.
Mhm.
And if there's a thoracic surgeon, if the cytology in the room is positive for cancer, they can go ahead and actually resect that cancer in the same setting without having to do anesthesia several times. So, for very early cancers, this has become a possibility,
Mhm.
and these are changing as we speak. New modalities are coming in, and the lung cancer staging early detection is going to be a booming space in the next 5 years.
Yeah, that's wonderful. It's definitely a multidisciplinary approach there. Now, we talked about who qualifies for lung cancer screening, what the test is, but in the United States, like how often are we actually doing the test?
That's an incredible, very important question, and that goes with the numbers that I was quoting. So, in the United States, on an average, countrywide, only 6% of the patient population is getting screened out of those who are eligible.
Hmm.
So, on the flip side, 94% of the population that needs to be screened is currently not getting screened. And a lot here has to do with information, lack of information for the patients as well as providers, and lack of awareness regarding the effectiveness of testing. At the same time, I have to say there is also, lack of funding at this time, federal funding towards this effort. And I'm hopeful that in the next 5 years and decade, this funding will increase because the impact of lung cancer is being noted, is being realized. So it also gets almost the lowest funding out of all cancers, but there are advocacy efforts and community efforts for education that are ongoing to make this better known modality.
I see. How have the insurance companies, Medicaid, Medicare, accepted this? Are they covering the low dose CT scan for screening?
Yes, low dose CT scan is covered by Medicare, Medicaid, and most private insurers when the guidelines are met. So the challenge, like I said, is more in awareness. So a few years ago, it was hard to cover, but changes are happening every month, every year, and now many eligible patients do qualify, but they may not know that they qualify, which is something that we're actively working on to change through outreach and education.
Great. Can you discuss the utility of biomarkers for lung cancer?
Yes. So biomarker is the future, is everywhere in the future of lung cancer. It is there in early detection, in diagnosis, in risk prediction, in and in treatment also. So, in terms of risk prediction, biomarkers are being used commercially. They're now available. If a patient has a nodule in the lung or a spot on the lung, you can use blood tests to tell what is the chances the patient has lung cancer, and it will classify it as low, medium, high, and you can use those that information to decide how aggressive you need to be with biopsy or resection in that patient. We already have biomarkers that are used very widely in the oncology treatment space. And now immunotherapies that rely on these biomarker tests are now being used and are effective in early lung cancer treatment also. For the future, extensive testing is going on to study the role of biomarkers like nasal swabs, breath analyzer testing, blood,
Hmm.
to see which patients could be or should be eligible to screening. And that may include people who smoke, and that may include people who don't smoke also, to in order to better enrich the population that we need to screen, besides just going on based on their age and smoking history. So those biomarkers are in study, and I think some of them should be gaining FDA approvals and getting commercial as the study results come out in the next 5 years or so.
That's very interesting. So, more to come on the biomarkers, right?
Yes.
Great. Jasleen, can you share a particular case or patient experience you had with one of your patients and lung cancer screening and how it impacted them?
Yes, every case almost I see, I at least once hear the patient say, "Thank God I got this test. Thank God I listened to my doctor and I got this test. Otherwise, I would have never known." And they almost always ask me, "What about the people who don't get this test? How do they get diagnosed?" And I tell them, sometimes they get diagnosed very late. If they're lucky, they will get incidentally diagnosed. But I think a case I remember is a patient who came with this very faint, hazy spot in the lung, and the spot was as small as 6 millimeter. And the issue was that it was his second screening scan, and in the first scan, it was about 4 millimeters, and you could see that it had increased, but it was quite small.
Hmm.
And we had a multidisciplinary discussion in our lung nodule boards, in our lung nodule clinic, regarding what could be, or is there a possibility of a modality to treat this patient if it is cancer, and it was a high risk for being cancer. So we engaged sort of a multidisciplinary approach here, where we went ahead and biopsied this spot with the help of robotic bronchoscopy and cone beam CT. And when we were biopsying it, we left a small marker there, which is called a fiducial marker, because for surgeons, it's very hard to resect such a small spot, resect and find such a small spot. So, because of that lung marking, the surgeon was able to go in a few days later and actually remove that area of the lung. And that spot was actually stage 1 lung cancer. So for me, that set the groundwork for how important it is to have these multidisciplinary conferences, discussions to make groundbreaking discoveries in treatment of lung cancer. And following that, we've done several multidisciplinary cases. Now, like I was describing before, now even we are using some dyes that can be used in the same procedure itself for the surgeon to go ahead resect the cancer. So that case sticks with me just because it opened so many doors for us.
Great. Thank you for sharing that experience.
Mhm.
What do you see in the future regarding lung cancer screening and artificial intelligence?
So artificial intelligence is going to take over everything in healthcare, just like the rest of the world. But AI, deep learning, machine learning is already getting ingrained into these areas, and mainly because we really do need AI. Because imagine the amount, the big volume of population that needs screened. It's millions of people, and every person doesn't need screened just once in their lives. They need to be screened every year. So there needs to be a record of who is eligible to screen, when is that person getting screened, and then to be repeating that screening every year. And on top of that, if they have a concerning finding, to make sure that they are then followed up even more closely, and how many people are getting followed up and they don't get lost to follow up. So in managing this large amount of data, AI has really stepped in. A lot of such cancers are showing up by accident also. Sometimes people are getting a scan when they're having a heart attack. They get a scan of the chest and they actually find a small spot that could be cancer and could grow into stage 4 cancer after a year or so. But there is now AI systems available that will read through all these reports and pick up concerning findings and then send it to a triage list. So one such system, a lung nodule program, exists within our early lung cancer detection program, along with the screening program, where AI and incidental lung nodule management softwares, they are running under the radiology reports, and they are scanning each report for such concerning findings. And there's a dedicated team where these reports are sent to, and those teams are keeping tab when the patient is getting discharged home, or reminding the patient, hey, you're due for your screening, you had your test last year, this was the finding on your screening. So, and sending letters, etc., which manually would require tens of people,
Hmm.
but and will still be fraught with errors. So AI has a lot of work to be done there, and has true value there. AI will also give us a lot more information on finding true cancers. So even though these spots in the lung are really common, 10% of them are actually cancer. So AI can give a lot of information by reading these actual images and doing machine learning, and actually giving us a score on which of these is truly cancer and which is not, so that we are not diverting our resources towards more benign disease. We want to focus them on finding more cancerous nodules earlier. So AI has a huge impact to be made there.
Yeah, let's see what the future holds, huh?
Yeah.
Great. Thank you, Jasleen. For those eager medical students listening to this, Jasleen, what advice would you give them?
I would say stay curious. Don't box yourself to a specialty in too early. When I was a medical student, interventional pulmonology didn't even exist. So keep yourself open. The field is evolving, and the most rewarding careers often sit at the intersection of multiple interests. And most importantly, I would say find your mentors and find multiple mentors and engage with them and keep them for your life. And if I hadn't found mine, I wouldn't be here. So I think those things I wish I knew way in advance at that time, but I have learned through the years.
Yeah, wonderful, Jasleen. What are some of your passions or interests outside the hospital? I understand that you're the president of an organization called Women for Interventional Pulmonology.
Yes. So I am passionate about empowering women in medicine, women in leadership. Because since I grew up, I realized what sort of social setups women go through, and very subtle situations where, women may be left behind, sometimes overall as a society pressure, sometimes needs, and self doubt, and those things that are pretty ingrained in our circumstances and how we grow up. So I lead the Women in Interventional Pulmonology group, and we, in addition to trying to do what we can for the interventional pulmonology field, we are looking to now grow to mentor younger physicians, younger leaders who are women, younger students, even maybe even go, if possible, to a more pre med school stage, to try to see if we can tell our story. And why not, why just interventional pulmonology, why just medicine, if we can inspire women to dream bigger and contribute more and more to the society. So that's our dream in that organization. Besides that, I like to, when I get time, I like to paint. I'm actually also working on my first book. It's about my ancestral heritage and about what we can learn from our roots. So if I can get anywhere closer to completing it, then you may hear more about it.
Sure, yeah, definitely. That's very fascinating. Well, Jasleen, it's been a pleasure having you on MD Roundtable. Before we wrap up, is there anything that you'd like to share with our listeners? Do you have any upcoming projects, etc.?
Perfect. Yes, I would just like to say we are about to launch our mobile lung cancer screening van this year. And we have launched our early lung cancer detection program just in the last year. So, if you're a provider or a community leader who is interested in partnering or just want to learn more, feel free to connect with me on LinkedIn or through my email. I can give you my email to you, Ted,
Sure.
and I'll be very, very happy to connect with them.
Great. When you say mobile lung cancer unit, can you describe that?
Yes, so it's a CT scan, a low dose CT scan that is housed inside a big truck. And we essentially call that our mobile lung cancer van, and there will be a radiology technician in it.
Hmm.
And instead of having the patients needing to travel to a CT scan unit, the CT scan unit can travel to them. And this is especially going to be used for underserved areas that are farther away from healthcare centers to educate them about this effort, educate community providers about this, as well as patients to make it more and more accessible.
That's fascinating. Yeah, good for you,
Yeah,
Jasleen.
thank you.
Thank you so much, Jasleen, for your time and being a guest on MD Roundtable. Keep up the great work you're doing with lung cancer screening, and it was a pleasure talking to you.
Thank you. It's been a pleasure to share my journey with you and talk about this life saving work. I'm truly grateful for the opportunity.
Wonderful. Have a great night.
Thank you. Good night.
Folks, if you enjoyed that episode, don't forget to leave a review of MD Roundtable Podcast, and don't forget to subscribe. Also, if you want to reach out to me with any comments or questions, feel free to go ahead and email me at drtedthatchandcarey@gmail.com. Once again, Dr. Ted thatchandcarey@gmail.com. I will also leave the email contact in my show notes. Thank you again for joining me. Have a great day.